All right, welcome to another Viva Learning webinar. I'm your host, Dr. Stephen Vorholt, and tonight we're going to be talking about implants in CBCT 101. And in true Viva Learning fashion, I've put in a lot of slides. So we're going to be moving pretty quick, but do feel free to put in some questions in the Q&A, and I usually have that pulled up. So if something comes up that I can quickly tackle, I will. But we got a lot to get through tonight, so I'll get going pretty much straight away. So the outline for tonight, what we're going to talk about, I'll do a quick introduction on who the heck I am, if you haven't heard from me or learned from me before. And then we'll talk about CBCT and what dentists think they need. If you're a dentist who's currently in the market or you may be in the market soon, there's three main things that everyone at a trade show would tell you need to focus on. And I'll kind of go through those and debunk them to a point on why those aren't necessarily the best things you need to be looking at. Then we'll talk about what you actually need. I've been using CBCT now for 10 years. I've used multiple machines, and I can tell you what has actually worked in my experience and made a big difference in clinical practice. So I'll tell you what you actually need, the things that aren't necessarily going to be at the top of the pamphlet, as it were. Then we're going to focus on how I use AIS 3D, which is my Acteon CBCT software, and what's possible with their newest release, the Optima, which is a machine that just was announced earlier this month. And then we'll have some time for some Q&A. So a little bit about myself. Like I said, my name is Stephen Vorholt. I went to The Ohio State University, graduated in 2013, and did a private scratch start in the greater Columbus area for about 5 years. It was at that point that I kind of realized that my passions were leading me towards implant surgery and not full focus family dentistry. And so I left Ohio and moved to Arizona to take a position at a company called Implant Pathway. Implant Pathway trains about 1,000 doctors a year on implant surgery and everything that's around implants, from restorative to IV sedation, sinus lifts, implants, etc. I also started a travel surgery business in the greater Phoenix area in 2023. And then now I am in Santa Barbara, California, doing a implant focused practice. So when I was in Phoenix, this was my setup. I had my home office. There you can see a screenshot on the bottom right of what AIS 3D looks like. That means I could bring in any CBCT DICOM set into the Acteon software, and I planned my cases, occasionally printed guides, as you can see my 3D printers in the top middle photo. And then I would travel to offices with these 3 Milwaukee packouts that barely fit in the SUV I was driving. And I would do about 2 or 3 times a week. I would be on the road doing surgeries, and it was a lot of fun. But eventually I wanted to settle down. My wife never liked Phoenix that much in the heat, so we kept going west and wound up in the coastal city of Santa Barbara. And I now have a practice here that is solely focused on dental implants, mostly with an emphasis on full arch. So let's talk about CBCT and what dentists think they need. These are the things, like I said, if you go to any sort of trade show, these are the 3 things they're going to tell you need to worry about. Field of view, voxel, and the rendering clarity. Okay, so let's get into these straight away. Field of view is simply how much you're going to be able to see in your CBCT machine. How big is the sensor? How much volume are you able to capture in the scan? Now, one thing to be considered, even if you have a large field of view machine, like the Acteon Optima, you can, of course, opt to do smaller views. So if you have an endo scan coming in or a limited exam on someone, you can just do a 5 by 5 centimeter scan, and that would be plenty for what you're looking for, right? So you don't always have to scan at the full size. Though I will tell you that in my practice, any new patient that I've never met before does get a full scan. Even if they're coming in for one problem area, I want to at least get a full scan of both jaws and sinuses so that I can, find other things. It's amazing the amount of dentistry you will find in a CBCT if you take the image and read it. A lot of asymptomatic endodontic, requirement kind of teeth as well. So just some examples of what those sizes get for you. My first CT ever was an 8 by 8. It was okay to see the tooth-bearing regions of the jaw, but pretty quickly was limited in some third molars, depending on the size of the patient. Would not get maybe halfway up the sinus, and so there were limitations. And so one of the things that I've realized is that I used to think you need to be concerned about how big of a field of view you shoot because of the liability. And really, what it comes down to is you just need to learn to read CBCT so that that liability is not an issue. Okay, don't be so concerned about getting a 9 by 14 scan. Just learn how to read a 9 by 14 scan so that you're not going to accidentally miss anything that you could be kind of in trouble for later. Because your dentistry, like anything, you're going to grow. Okay, these are x-rays I took on a 12 by 10, and it's amazing what you can see in a 12 by 10. That's probably the minimum I think you need to have to do full arch. So these are cases I've done in the last couple of months. And you can see the entire body of the mandible. You can see to the top of the sinuses on most patients. Can't quite see the TMJ on both sides, but you can do adequate full arch surgeries at a 12 by 10. The new Optima scan, a little bit larger. You can see oh, let me go back, sorry. The new Optima scan is a 17 by 12 and does allow you to get above the orbit. And so if you start to do zygomatic implants, or you're an oral surgeon or an orthodontist who's looking for the nasion and things like that, then it behooves you to get a larger field of view scan. Okay. And so case in point, when I started out in dentistry, I never thought I would do all on fours, let alone potentially things like zygomatic implants, but it's nice to have a machine that will grow with my clinical skill set. It's something that you don't have to be limited by. Whereas the 8 by 8 that I got pretty quickly realized if I wanted to do sinus lifts, I need to get a different machine, and that's not fun to pay for that twice. Voxel size is the details you're going to be able to see, so essentially the slice thickness. And what this study showed us was that at 0.2 millimeter voxels, that's kind of the limit to where you can kind of anything better than that, you're still seeing everything. In this study, they were looking at vertical bone defects. And so could you detect vertical bone defects at these different levels? And 0.2 millimeter voxel appeared to be the main differentiator. And I think almost every major CBCT out there is going to have a 0.2 millimeter voxel at their largest field of view. One thing to consider is that as the field of view shrinks and the machine can be a little bit more exact, the voxel will also shrink. And so on the Acteon machine, for instance, if you do a 5 by 5 scan, let's say you want to do an endo scan, the voxel is 0.07 millimeters. If you do their 12 by 17, the largest one you just saw, it's 0.2. So you still have quite a really nice diagnostic image. But if you are doing endo or something that you really want to see fine slices, you can just pick a different field of view. And then we have rendering clarity. This is the thing you'll see at at the trade shows on the big screen is how pretty it looks when you scan somebody. And what is a rendering truly good for? A rendering is simply a software model of the DICOM data set, and all machines are shooting the same type of x-rays into very similar type of sensors. There's just different algorithms on how the machine and the software will then show that in a three-dimensional model. There's not much functionality in the three-dimensional model besides maybe gross anatomy. Like here you can see the mental foramen, or in the case on the top right, a double foramen, and the bottom right, a triple foramen. But you can't trust the 3D rendering for, caries or for big, small things, right? So we might be looking at general anatomy with the rendering. So is it what if that wasn't the limiting factor? For instance, in my CT, there's lots of different rendering templates. And so the one on the right, on the left is the bone template. And then the one on the second in is, the enamel template. So they have different settings based on the Hounsfield units, which is simply a measurement of density of the scan. And so you can make your own templates even. You can say, hey, from this Hounsfield unit to this one, which based on the literature is roughly enamel, make it this color. And for bone, make it this color, and so on. And so there's a lot of different templates, and you can even tweak it yourself if you're looking for different things. Like maybe you're looking just at root canal fillings and you want something that has a very high Hounsfield unit. But what if the algorithms were no longer a limiting factor? In today's day and age, we have bone segmentation tools that are harnessed the power of artificial intelligence. And this is the same exact CT. You see on the left 4 renderings that are just software renderings of the DICOM dataset. versus these two, which are the same. One's just transparent, which is an AI bone segmentation. So it was gone through an AI reader for a handful of minutes and spits out an extremely accurate model. Now, not as accurate as an intraoral scanner as far as the teeth are concerned, but I have made multiple bone-borne guides that snap onto the jawbones and they fit very well. So it's amazing now that even if you have a software company that's rendering is maybe not the prettiest or the clearest, you run that DICOM data set through an AI bone segmenter and you have something just as good as any other machine. So what does dentist actually need? Field of view is great to make sure you don't limit yourself, like we talked about. Voxel, everyone has a good enough voxel. If you're an endodontist or something, maybe look at something like the Optima that has a 0.07 at its finest. And then the rendering is kind of all just for show because nowadays with AI tools, it's not that necessary. Okay, so what do we actually need? Things we should be focused on, in my opinion, is the software capabilities. How are you actually going to interact with this machine every time you take a scan? It's not that important that the field of view is the same because you can get the field of view from every other machine in the industry. But what software on the computer are you going to be utilizing? Whether it's something that looks good so you can show your patient, whether it's something that's powerful so that you can do multiple things with it. The practice flow, how easy is this to train staff on? What's the actual footprint size that as it is in your office, right? And diagnostic quality, which we kind of hinted at earlier with the voxel stuff, but we really want to make sure that for whatever type of dentistry you're attempting to do with the CT, you have one that's good enough to pull it off. So there's a couple different ways to do software on a CT. You can have a native CBCT viewer, simply comes with the machine. It allows you to view the scan. You can see the rendering. You can go through slices. You can diagnose and treatment plan. Maybe you can drop some implants in there. The middle one is the native viewer that also has guide design built in. So now not only can we treatment plan implants, but we can actually fabricate some things in here. We can design and fabricate some things for export and then either 3D printing or milling or send it to a lab. And then on the far right is the third-party guide design, which is things like Blue Sky Bio, ExoCAD, 3Shape. Some of those are lab tools more often than not, but these are things you have to take your CT DICOM out of your machine and re-import it into that software. So it's nice when you can be in the middle there and have one software that does all of it. You know, instead of having a care stream that now you have to export the DICOM, re-import it into some other software to actually utilize it. So what's the general workflow for guided surgery? We'll just touch on that real quick. First, we're going to diagnose and treatment plan based on the patient's whole medical and dental history. Of course, we're not coming in just because they're missing one tooth. If we're going to take the CT, we need to read the entire CT. So we expose the CT. That is a relevant field of view. Like I said, if it's my patient's first ever or they're a new patient, I am going to get a full field of view scan so that I'm not treating number 19 and missing, a impending abscess on 14, for instance. Going to read the CT completely. We'll talk about how I read CTs in the second half of this webinar. And then we're going to bring in our intraoral scan. So I would venture a guess that most offices that have a CBCT and a machine that, costs tens of thousands of dollars also has some sort of digital scanning, but I'm sure there's some that's not the case. But if you do, then you can bring in that STL file from whatever your scanner is and align it to the CT, and that's what allows guide creation to be possible. We're using the hard tissue markers, aka the teeth, and lining up the teeth in the rendering with the teeth in the iOS scan. Then we can do a wax up. We can do a digital wax up here if this is tooth number 19, so we drop a little fake tooth in the 19. That way we can plan our implant crown down and put the implant where it needs to be to support the crown that the patient needs. Then, of course, we're going to look at the STL overlay and make sure that it's well stitched. That's the most important thing, to make sure that our guide is lined up with the bone we think it is. And we can take a look at now the actual CT data and make sure that buccolingually we like where the implant's positioned, away from the buccal plate, plenty of bone circumferentially to it, and then mesodistally as well. Make sure the angulation is all good. Once you've done that, which is you're probably already doing that already if you have a CT and you're planning implants, making the guide becomes a simple kind of step-by-step process. We're essentially going to tell the software that we want to make a suck down over the model with a very specific sized circle cut out over our planned implant. And that circle would correspond with whatever surgical guide sleeve we use or chose in the software. In this example, it's a BioHorizons, so there's a BioHorizons sleeve. It's the green thing you can just barely see at the top of the guide. And you can do things like create windows, you can emboss text, you can trim it, smooth it, etc., and make it, relevant to what you want. So that's the workflow, and that everything you saw there was screenshots from the AIS 3D software that comes packaged with the Optima or the Prime from Acteon. But let's look at some cases, for how we can utilize this. So here we have a case, very interesting case. Not often you get a 4-unit implant bridge where there actually is a tooth posterior to it. So it's really important to do a wax up in long spans like this because it'd be very easy if you did this freehand to accidentally kind of evenly space the implants. And then your one middle implant happens to be kind of in the embrasure space between two teeth. So ideally, we're going to plan this to be coming out roughly where the 3 of the 4 teeth are. And one thing you might notice that I would ask if we were in person, does anyone notice anything interesting? Is that the middle implant, in this case number 4, is offset just a little bit buccal to the other two. We don't, this happens so rarely, but if you do want to have a 3 implant bridge, you don't want to have them all in a straight line. You should not be able to draw a straight line between all 3 because then the axis of rotation and excursive movements is all on one axis. So offsetting that middle implant by just a little bit allows the forces to be a little bit friendlier when the patient is actually chewing and functioning on this implant. So I think to this date might be the only case I've had like this that happens to have 4 teeth, but it's kind of an interesting thing to look at. So the guide gets seated just to confirm it's fully seated. That's why the windows are so nice in the front. I still do a full thickness flap. It's pretty rare that I'm going to be punching through a guide unless there's just an absolute abundance of tissue. And it's still a trust but verify thing with me. I'll still do the initial pilot drill, take the guide out, put the parallel pins in, take a PA if you need to, and just trust but verify that everything's lining up as you expected it to. So in this case, fully guided surgery means the implants went through the guide as well. They were placed and they were buried with cover screws. Okay. Another example, a patient I saw here at my practice in Santa Barbara, they're missing the molars in the upper right, and they just want one more tooth so that they're kind of chewing a little bit more on the lower right. And one of the things I like to do with sinus lifts, if I'm doing a vertical sinus lift, is I'll make a pilot guide that stops 1 millimeter shy of the sinus floor, which is the typical first drill for most sinus lift techniques, whether it's Versa or Casket, or there's any number of different ways you can approach a vertical lift. But to take the guesswork out of it, just go with a guide that goes 1 millimeter short, and then you can complete the rest of your surgery however you deem appropriate. So in this case, it was planned with a little wax up tooth. The guide goes in, just a pilot guide, like I said, just the 2-0 drill goes right through the tissue. So here's the guide seated. You can see in this picture how important the windows are. So I'll tend to put windows, every couple teeth, and you can see how intimate that guide is fitting, which is really nice. And you can make sure that it's down all the way. Okay. So there's our implant, small, just a vertical release flap on there. And for simple cases, I tend to take the final impression the day of placement for single implants. Even in cases like this where I end up burying the implant, I will go ahead and take the final impression. I'll see the patient back at their 1 or 2 week post-op, and if everything's going well, I'll go ahead and order the crown. So when they come back at whatever timeline you decided, we simply make another incision, re-expose the implant, and place the crown. And you'll never have a better tissue adaptation than if you just allow the crown to be the tissue healer. So it works great in posterior cases, but you can keep it really simple. And it's like kind of the quote unquote 2-visit implant, as it were. Here's another one, just pilot guides. I would say most of my guides are pilot guides anymore because I like the flexibility. And after you get through the pilot, most of the drill sequence is pretty simple with tapered drills. So save yourself some money. Don't buy a massive guided kit. Just get yourself a couple predetermined length 2-0 drills. BioHorizons sells some great ones. And yeah, it's a piece of cake to have a pilot guide made. It's less expensive and certainly easier to use. So in this case, because of the abundance of attached tissue, I did just punch it right through the tissue. And then I just made my incision right over the little punch through the tissue so that there was no hole in the flap afterwards. And there again, you can see the impression coping. So placed the implant, high torque, took the impression coping, put a little healer on it. Now, unfortunately, it'd be nice if I had done a custom healer here to have a little bit more of a rectangular emergence. But while you're placing these crowns, you can ask the lab to ignore the gingival contour and just give you a fully anatomic crown that you want and make small releasing incisions mesial and distal to this and get the crown to seat. Okay, on to footprint and practice flow. So there's three main options. The sitting option is a little old school. That's the old iCat. Takes up about the size of a whole operatory. Then you have, I'd say most of the machines are standing options. They are mounted on the floor. A little bit more difficult to maybe install and certainly more difficult to remove. And in my practice here in Santa Barbara, the practice owner that I bought the space from didn't even have a panoramic machine. So there was no previous space for a pano. Now, if there is, the wall-mounted units from Action are great because they're about the same size as a pano and they mount right on the wall. You just install a little bit of backing behind the drywall, mount it right on there, and the whole install takes about 2 hours. In my space, we had to take down a small closet, and we were still able to fit the Optima because it's such a small machine. It's an amazing bang for your buck as far as the size. So if you're going into an older space, upgrading a previous pano, or if you're like me and you're in California and space is absolutely difficult to come by, something like that is really nice to have. Make sure all machines have 2D capabilities. I think that's true pretty much across the board these days. Used to be you could get a machine that was just 3D or just 2D, but now most CTs that I'm aware of have 2D capabilities as well. Sometimes they'll take it simultaneously with the CT. Sometimes they'll have to flip the sensor inside the machine. It's actually 2 rotations around the patient. Something that's very important. Can we diagnose what we need to see and be safe? What we're looking at here is a slice of the IA as it exits the mental foramen. And that red shaded area is what's called the anterior loop. It's any portion that's more anterior than the foramen itself. On about half of people, we have some version of a loop. And the biggest way to determine if it's a loop or if it's the incisive canal is the luminal size. And so you can see there the orange dotted outline shows how large the lumen of that canal was. And so you can be assured that that is actually still the mental nerve. And then that offshoot, to the right of the red shaded part is the incisive branch, which is not something we worry about so much. But it's important to be able to see what you need to see. Another example of the ability of 0.2 voxels, even around a lot of metal artifacts, is if you look at the white arrows, you'll be able to see that small notch. And those of you who have done lateral sinus lifts or make it into lateral sinus lifts, this is an anatomical feature you will look for when you attempt to do a lateral window, because oftentimes there is this interosseous branch of the PSA that runs through the maxillary lateral wall. And you want to know where it is so that when you're accessing your lateral window sinus, you can either avoid it or prepare for it. Because these bleeds, while not life-threatening by any stretch, can be annoying, and they can stop your ability to see and efficiently do the surgery. And so I just thought this was a cool photo showing just the small size of that little notch and that it did show up on the CT. And you can see a pretty large arteriole there that's actually attached to the Schneiderian membrane. So it's either like this, where it's attached to the membrane, but they had a little channel in the bone. It might be completely interosseous, a canal that's completely inside the bone, or it could be completely inside the Schneiderian membrane. Here's the incisive branch of the AI. So you'll see this on Facebook every once in a while. Someone will post a panel like this and say, oh my gosh, the loop is so long. Can we even place implants here? And what they're usually pointing out is the incisive branch. And that is not the loop. You can see a great example here of how large the luminal size is of the IA and how it exits the mental. And then as it shrinks considerably, that is the incisive branch of the IA. And the only reason you need to be concerned about that is potentially some bleeding And so you might be doing a surgery, a full arch surgery that you have to cut through that because you're trying to place implants for an overdenture or a fixed arch. And you'll get these just kind of a constant stream of blood. Okay. And if that's your first time, that might be a little bit alarming. But the most important thing is that intra-bony bleeds are pretty easily taken care of by either doing what we did here, which is place the implant, or some sort of tamponade to get it to stop. You know, it could be bone wax or it could be bone graft or collagen or something to that effect. But in most cases, you're drilling it to place an implant, so you just place the implant. And the implant is a pretty good way to stop the blood. So that's the only thing you really got to worry about. It. The sensory innervation that it innervates is the anterior teeth. And in most every case you're going to be coming anywhere near this thing, there won't be any teeth left as, you know, as pictured. Okay. So let's spend the back half of the webinar talking about how I use CTs and how I read the CTs. Because if you're new to CTs, this is probably something you're going to want to pay attention to. How to efficiently read a CT so you're not in your office for 20 minutes each one trying to figure out what's going on. So the nice thing about the newest software is it's all AI driven. So what we see here is a couple different 12 seconds to automatically align an intraoral scanner, so you no longer have to pick the points. Does a really nice job doing that. About 20 seconds for it to automatically do your panoramic curve. So that's for maxilla and mandible. We'll talk about that curve and what the ideal curve is. And then a little bit longer, about 30 seconds for it to find the nerves for you. So in a matter of about a minute total, you or your staff could have brought in the patient's scan, done the panoramic curve, and detected the nerves. And so what I imagine is if you see a new patient, your hygienist or assistant could have just clicked these three buttons before you came in. And when you arrive, there's already an aligned intraoral scan. The panel curve's been drawn and the nerves have been mapped. And it's time for you to look at them reading. Okay, so how do we read this in a practical manner? When you open a CT, you're going to have first what's called the scout plane. The scout plane will have these 4-panel views. You're going to have the rendering. You'll have the axial, sagittal, and frontal. And it's important to know how to read all of these really quickly before you bother going through the panoramic curve and all of that kind of stuff. This is a really nice one to read. And what I'm looking for essentially is I'm in my office or I'm in the hallway before I've met the patient. I just want to do a quick scan to know kind of what I'm walking into. Okay, am I walking into a heavy caries case, a perio case, an edentulous case, a terminal case, a pathology case? You know, that's what we want to know. Okay, so the we're going to look for symmetry first, and kind of almost like when we were younger and did the magic eyes and made ourselves go cross-eyed, we can kind of let our eyes focus on the whole screen, and then we can focus on looking for things that seem out of place. So here's the initial read. It's about 90 seconds long, and then we'll break down exactly what each one of these does. Okay. The first thing I do, though, like you saw there, is I align the axial slice with the hard palate or the maxillary occlusal plane, because that's going to give me my most symmetrical view down the middle. And we're reading the axial slice in the lower left first, even though I'm clicking on the right side. Now we're going to go front to back. So the top right is what we're viewing as we go front to back through the coronal slice. And then lastly, we're going to go right to left or left to right, whichever your preference. And we're looking at the bottom right one now. And so we're doing a quick read, and we're going to break down each one of these and what's important in each one here in a second. And then lastly, you can certainly will look at the 3D rendering if you want to look at the gross anatomy, you know, where the mental foramen are, infraorbital foramen are, some large defects, tori, we can see there, greater palatine foramen, etc. Okay. So I would say on average, once you get good at this, about 1 to 2 minutes would be enough for you to quickly gauge kind of what we're looking at when we're walking into the room to meet the patient. And of course, you're going to take more time once you're in there with the patient and you're talking with their chief complaint. So let's start about the axial slices. So we're going to now break down exactly what you just saw. And the first thing I'll do is look at axial. That's cutting the patient horizontally. And we're going to slowly scroll back and forth with first impressions. Now, the thing about the axial slices, this is the one that has the most parallelism. So a lot of times you can just kind of look left and right and see where things don't match. And that's a really simplified way of looking for pathology. But we're also going to focus on these 6 main regions. We're going to look at the sinus and the nose. We're going to kind of pause and go back and forth on the root apices of the maxillary teeth, contact points, and then the same thing on the bottom, contact points, apices, and then the mental foramen. The four things in the middle, the apices and the contact points, are where you're going to see most of your pathology and caries. So we're going to take a little extra time there to do it. So before I hit play on this video, we'll see the list on the top of the things that we can see. You know, sinus thickening in the upper right. Now the right is on our left. You see the little R here. Okay, it's not like we're looking at the patient from under their chin. We're going to see some nasal mucosal thickening, which you can already kind of see in this initial slice. On the right side is a little thicker than the left. There's lots of radiolucencies on the maxillary teeth. There's a huge defect in number 4, so that'll show up on the right side as well. And some small lingual tori. So now we'll see as we go through back and forth. There's the sinus, like a polyp in the sinus. The right nasal passage is a little bit more occluded. And we see some little pop-up radiolucencies on some of these apices of the teeth. Okay, now we go to the contact points, the bottom contact points. You can see some caries underneath that amalgam. Some more radiolucencies, especially up here in the front right there. You see on number 25. Okay, so that could be your initial read for the axial. So we're seeing a patient right now who has some broken teeth, some infected teeth, and maybe some sinus infection concurrent with that. Next, we're going to go to the coronal slice. So this is the slice that is cutting the patient, you know, from their nose to their throat. Okay, so this is the best view for the buccal lingual dimension of the back teeth. You can look at the nose and the sinus very, very well. And you can see the mental foramen. Not the greatest view for the anterior teeth. You're going to kind of go right through past the anterior teeth because you're kind of seeing them at a weird angle. But take a look at the things we see in here. Sinus thickening in the upper right. We already saw that in the axial right, but now we're going to see it from this other view. This is similar to when we all took the DAT and we had to know how to do the perceptual abilities test. Nasomucosal thickening, same thing. We're going to see a lot of the same things. Okay. Look at the abscess on number 13, which is going to show up on the right side of the screen. You'll see it does not perforate the sinus floor. That's important to know. If you're going to be extracting number 13, it's nice to know if there's already a perforation that you'll have to close or not. So let's take a look at this. So see the nose and the chin, and now we're back into the premolar region pretty quickly. Lots of arterioles there in that maxilla too. You see the nose in this view, you can see very clearly the right nostril is very occluded. Maybe they need to see an ENT, maybe they have before. Okay, and we get a good view of the posterior teeth. So now we're going to use the sagittal slice. So sagittal is left to right. We're slicing the patient down kind of from their nose to their throat. That's the slice direction. And this is the really good view for the anterior teeth. So any trauma up here, lesions, fractures, etc. If you're doing immediate implant planning, you'll see just how big the sinus goes as far as posterior, anterior. And if you're an airway doctor, this is the view you'll pause at the mid-sagittal and take a look at the epiglottis and the airway and all that kind of stuff. Okay, you also get a decent bite wing-esque view of the posterior teeth. So here's what we see in this scan. Once again, a lot of the same stuff, right? Upper right maxilla has a pretty large defect where they had a tooth extracted. Take a look at the anterior root positioning. They have very buccal roots. If you pull that, it's going to be hard to keep any sort of buccal plate with them. Good to know. You can see the large apical lesion on 13 with a curved root and no sinus floor perforation. So there's the large defect here at 4 and 5. We're going to scroll past it again. Hard to say what happened there. As we come forward to the anterior teeth, we get a really good view of how buccally positioned these front teeth are. And there's the abscess at 25 right there. And then here's this little hooked root on 13. But there's still a bony wall between it and the sinus. So that's good stuff to know. Okay, and we get a good view of this person has a lot of abfraction lesions. That's why you're seeing a lot of those weird cuts right at the CEJ. And last, we're going to use the rendering. So not diagnostically accurate outside of gross anatomy, but we're going to be looking for mental foramen. Obviously, they have large mental foramen here. There's that large defect in 4, some broken teeth. We can even see, sometimes you'll see abscesses through the bone. The nasal floor, infraorbital foramen. Okay. And if we flip the patient around, we'll be able to see the genial tubercles. See the mylohyoid undercut. There's the greater palatine foramen and some tori. Okay, so that can give you an idea if you're going to be doing surgery, what you can expect to run into. Okay, now let's talk about the panoramic curve. So you've done your initial read. Whether you do this inside the room or not is up to you. Like I said, you could have your staff do this via AI anymore. So when you walk in, it's ready to go. But what's nice about the pano curve that those three slices didn't give us is they give us a tangential slice around the entire pano. So as we scroll from tooth 18 to 31, every slice we look at is going to be the buccal lingual slice of that tooth. Instead of having to use, like I said, the coronal for the posterior and the sagittal for the anterior, we're kind of combining the two things, okay? Now, one thing to consider is that each arch is a different shape. So some machines will have a kind of combined pano curve. You'll just have one pano curve, and it'll kind of have to split the difference, but that means neither of them are ideal. In AIS software with Acteon, you have a maxillary plan and a mandibular plan, and what that allows you to do is use the most appropriate shaped pano curve for each arch because they're different shapes. So in the maxilla, we want to be parallel to the hard palate. So the first thing we're going to do is align ourselves to the hard palate. Okay. We want to be roughly at the root apices. So that's where you can see just a couple root apices here. You want to go ahead and bisect through the pterygoid plates and just roughly go along the arch form. Okay. It's a horseshoe. Most maxillas are some form of a horseshoe. And this is the view you'll get. So we can see some larger ASA vessels up here. We can see part of the teeth. But the reason we go to the level of the apices is because that's where we're going to see most pathology. So this initial slice, which is it's 0.2 millimeters thick, it's the voxel thick, is going to show you some anatomy based on where you put that slice. Okay, so that's my preferred way to do a maxilla. Now, of course, we're going to expand on that. We're going to make the panoramic focal trowel 10 or 20 millimeters. But at the initial, this is what we want to see. Nice, clean sinus, too. Okay, in the mandible, it's not a horseshoe. It's either a V or a U-shaped or maybe even omega-shaped. And so generally, we're going to go parallel to the occlusal plane, often the same as the maxillary one. And we're going to go mid-root. Now, why do we go mid-root? Because the roots in the mandible tend to be pretty much straight up and down. So they don't flare as much as the maxilla where we need to kind of go and find the apices of the roots in the maxilla. So we go mid-root in the mandible, just follow in between the plates, okay? And ideally, if you can, take the time to line up these nodes to give you a really clear view of the nerve. Not necessary, but it makes the next step a little bit faster if you're not using AI. So we have our pano curve. Our initial curve was whatever the voxel is. So we simply change the thickness to something we're more used to reading in the panos, 10 or 20 millimeter focal trowel. And now we have an extrapolated pano, if you will, that we can very easily navigate. So both CT softwares have different views. This is a view template that I like to use, which has the rendering pretty large. It has the CPR, which is the curved planar reconstruction, aka pano. And then you have the cross-section tangent, which is just 90 degrees to the cross-section, and the axial. And that's going to show you everything you need to see, especially if you're doing implant planning. Okay. So what we're going to see here is as I scroll from tooth 31 area to 18, if you focus on the top right screen, that's the one you're going to be looking at. It's the tangential curve, the cross-sectional curve, and it allows you to see every tooth in buccal lingual dimension, which is what we're missing in every other two-dimensional x-ray. That is why for implant planning, a CT is, I think, the standard of care. Okay. Now, we also can rotate along that axis. So if we find a tooth we want to look at, say in this case, number 22, we can line it up with the axis of that tooth. Let's go ahead and zoom in, and we can drag the slider and just do a whole spin around that tooth. Okay, so you can see it from all angles. So if you're planning an implant, this is extremely valuable when you plan the implant to be able to see it from all sides. Okay. We're going to talk about some important anatomy to identify for dental implants now that you have a CBCT. Okay. So in the maxillary arch, there's more things to identify. But the sinus is important. The osteomeatal complex, which is where the sinus drains. If you get into sinus surgeries, even if you just want to do simple vertical approach, with a Versa drill or a cast kit or something like that, it is important that you have a CT that views the osteomeatal complex, which is in the most superior posterior medial, so back up and towards the nose in the sinus, and that is where our sinus drains. So, for instance, my first 8x8 CT almost never showed that. And so, if you did a vertical sinus lift, they got a massive sinus infection that turned into a fungal infection or something like that, and your CT never showed that maybe they had a occluded ostium the whole time, you really don't have much legs to stand on. So make sure if you're going to do sinus stuff, you get a machine that is adequately large enough to visualize that. We look at the PSA artery, which is what we already looked at once, the interosseous artery, and all these different neurovascular bundles. Okay. So the sinus, if you're placing implants or just getting into implants, it is inevitable that you will do sinus lifting. Unless you really just want to touch the surface of doing simple, straightforward lower molars or something like that, because you'll realize that more than half of the teeth that patients lose are in the posterior maxilla for a number of reasons. And a lot of times, if they've lost a tooth for any amount of time, or even if they haven't, they're going to need some sort of sinus augmentation. So it was the second course I took after my intro to implant course was something about vertical sinus lifts. So it's very important that we become very comfortable with the maxillary sinus. What you see here in the middle near the nose is at the middle meatus in the concha there, the middle concha, that is where our sinus drains. So it's actually quite high. And a lot of CTs that don't have a high field of view will miss that. They'll cut off the sinus about halfway. So even though you might say, hey, that sinus looks super clear, they have no symptoms, there might be a polyp or there might be some inflammation up in that osteomedial complex that does not allow for any loose graft to escape, and that can cause infections. As you advance in your implant career, you will maybe likely, like me, end up learning lateral sinus lifts, which if you told me that 5 years ago, I'd be doing those routinely, I would have scoffed at you. But this, once again, the evolution of your career is sometimes hard to map ahead of time. That's why you should get a CT that can grow with you. It's really important that we understand this very, very well. Okay. So what are some of the pathologies you'll see? We've seen these all in panoramics, of course. Remember, dental school pathology class, we had to learn about these pseudocysts or these mucus retention cysts. Okay, they're generally dome-shaped, and they lie on the floor of the sinus, and they're pretty easy to detect and determine. They're completely benign. If you're going to do a sinus lift, the only thing you got to make sure of is that by lifting the sinus, you're not going to then occlude the ostium, which you can see here. This is the ostium as it leaves the sinus. See how high that is? You want to make sure that if you have a large retention cyst, you're not going to push it and block that. Okay. Things like this that are a completely opaque sinus with some destruction should be referred to an ENT immediately, and probably have it also sent to an oral and maxillofacial radiologist. Now, one thing to consider, if you're sending all of your things to an oral maxillofacial radiologist, there's nothing wrong with that. It's just going to get kind of expensive. I still send probably about 4 or 5 cases a year, and out of the hundreds that I view, to a radiologist, almost as a cover your butt kind of thing. Because if there is some pathology, I want to have the liability of that passed on to a specialist in radiology. And so once you send your radiograph to a radiologist, you are no longer liable for things that could be missed in the scan. So if you see something like this, not only do you tell the patient they need to be referred, but I would send this off to a radiologist as well. Here's a better view of the ostium and how it can be, sometimes can be tricky to see it all in one shot like this, and because it tends to curve posterior anteriorly as well. So, but it is important to make sure you can map out and see where it's draining before you attempt any sort of sinus surgery. Okay, we talked about this before, but here's a different version. This one's interosseous. So this is the interosseous branch of the PSA, and usually they're quite high in the lateral wall of the maxilla. Sometimes just anatomical differences or resorption. These might come into play if you end up doing lateral sinus lifts, and they can become an issue. You can map these things in the software. You can do like third-party mapping, not just in nerves, but you can see here we've mapped all these little arterioles. They even shoot down behind and exit on the palate. There's a lot more vascularity in the maxilla, the mandible, but once you start looking for it, you'll see it all over the place. You will see it all over the place. Okay, so how do we approach that? In this case, we knew there was going to be the arteriole right there. You can see we've be very carefully with the piezo technology. That's the Acteon cube that we use. We've removed the bone around the arterial, and then you can do a suture ligature, or you can burn it, cauterize it, or burnish it until it's gone. Or you can work around it if you have that kind of patience. But you can go in there and tie it off there, tie it off in the back, and then pop through. Okay, this is the one we saw earlier. You could just see this little indentation. It's not an artifact. It's actually that little notch we saw, that very quite large artery going through the Schneiderian membrane. Okay. How about the infraorbital nerve? Pretty high. It's about 3 centimeters from the CEJ of the first premolar. Not a nerve you're going to hit very often unless you're doing some larger maxillary surgeries like a sinus lift or an all-on-4 or something like that. But you can map this in the CT before. So rather than just going with anatomical averages, you can certainly map this in the patient CT, know exactly where to inject. Okay. I have had some cases of paresthesia of that nerve from large flap reflections, bruising, swelling, etc. It's almost always self-resolving, like it was in this case. The nasal floor or the piriform rim is an important anatomical thing to know for all NX surgeries where we need to get nasal rim engagement, because that is a very dense cortical border. Now, one thing you'll notice, if you do start flapping the patient under the nose and you're, elevating the gums and mucosa, the patient will likely tell you when you get to the floor of the nose, because it's innervated by a deeper branch of the V2. And so you might have done all the infraorbital nerve blocks, ASA, MSA, PSA, and they'll suddenly feel it when your tool gets to that nasal floor. So be prepared to maybe inject either some bupivacaine directly into the nasal mucosa, or you can actually go up through the nasopalatine canal and kind of bury the hub and get some anesthetic up there. In some cases, you can even elevate the floor of the nose, like in here. There's what you can maybe barely see is there's a collagen membrane there first, and a curette that was used to elevate the sinus floor. And here's the implant osteotomy, so that we can get a slightly longer implant to engage the floor. Okay. Speaking of the nasopalatine neurovascular bundle, rather than just getting nice and numb by putting your needle all the way up this thing to get the nose numb, what do we do when you run into this thing in implant surgery? Just like all nerves, like the IA and the mental, there's a 2 millimeter safety limit. That's ideal. The worst thing you can do is encroach on a nerve and not, like on this nerve, not the IA, because if you encroach on it closely but without severing it, you can get this kind of itching, painful sensation. So for the nasopalatine in particular, no other nerves, you can remove it entirely. Okay. So a lot of times it's in the way of where a nice implant would be. So it can be completely debrided and removed. The contents can be removed, and the innervation that it does to the anterior palate will be picked up by the posterior greater palatine artery and nerve over a handful of months. That the patient really, in my experience, doesn't say much about this while they're healing. It's not something you notice as being gone. Okay, so let's say in this case, we have very little bone in the premaxilla. So we have some sinus lifts in the back, but our implants are very far back, okay, into the lateral sinus lifts, and there's no bone from kind of first premolar to first premolar except right there in the midline. And so if you look at your CT, you don't have to go through the canal space particularly. There's usually a lot of really good bone just anterior to it, but it still makes sense to remove the contents of this canal, okay? Because you don't want to, like I said, have that cause a neuroma or something like that by leaving a nerve remnant. So we can go in there and remove it with curettes and some small diamonds or small carbides, and just go in there and kind of remove all the contents. And you can drill right into the nerve canal itself. And that's a lot of good, healthy, bleeding bone to place an implant. A good friend of mine, Dr. Bart Silverman, oral surgeon in New York, calls this God's osteotomy because it's very useful when you need it. Okay, implant goes in with a high torque, and the patient is closed. And now we have an AP spread for this, in this case, an upper snap indenture that has some support in the front, okay, as well as the back. The GP, branch of the V2. If you want to do a V2 block, this is where you're going through, okay? It usually comes into play if you're doing some soft tissue harvesting or if you're doing a really large flap in the back. And controlling this bleed can be very difficult sometimes, so we tend to just completely avoid it if possible. Deep mattress sutures are necessary if you get a bleed in the greater palatine foramen. Okay, but you can easily map this on the CT and know where it is. It does exit kind of high above the pterygoid plates in the venous plexus, and that is why you can place a needle in there, aspirate, very important to aspirate, make sure you're not in the venous plexus, and you can do a V2 block and get the entire hemimaxilla numb in one go. Jumping down to the bottom, the most dangerous part of doing PA in a pano is that you don't see that buccolingual dimension. A lot of times, the submandibular fossa can be pretty aggressive. Now, in this case, it's not a very aggressive undercut, but it's not hard to imagine drilling straight down and perforating the lingual plate. There's a lot of things that have to go wrong to perforate the lingual plate. You have to have not planned very well, or maybe didn't have a CT, and then you have to ignore quite a bit of tactile feedback on the drills because it's a very thick lingual plate to perforate through that. So you have to be really careful. You should always be thinking, what am I feeling and why am I feeling it? If that's the case, okay. There's a big blood vessel down there that runs deep to it. You want to avoid. And if you do perforate it, you do need to remove that implant and just make sure that you monitor the patient for any hematoma formation or bleeding under the floor of the mouth, because that's the big fear. Sometimes in a panoramic, if you're just doing two-dimensional x-rays, you say, oh, look, we have plenty of bone here to put a 7 mm implant, maybe even a 10 on this side. But it's the CT that shows us how grossly, how large these undercuts can be, where we can run into problems very quickly. And so if you're convinced you have enough bone and you think you're just drilling through some denser trabecular bone and you push harder, you can perforate the lingual plate and be in the kind of the no-no zone, as it were. Okay, short implants are a good option. A lot of different short implants out there now, and some companies have implants as small as 4 or 5 millimeters. In this case, these are the BioHorizons, I think 6 mm implants, and they can be restored with very tall crowns. This review talks about crown to implant ratio, what it needs to be, roughly 2 to 1, kind of the opposite of what natural teeth is. Okay, so root to crown ratio is about 1 to 2. You should have twice the root. With implants, it's 2 to 1. You should have at least half the implant length, assuming you've controlled all the occlusal properties. So you can see here, yeah, it's kind of a long FP2 tooth, but who's looking back there besides you and maybe the patient? We're just restoring function. All right, we've all heard of this nerve, the IA. It's a very important nerve to know. Safety zone is critical above and beyond this thing. We don't want to even get within a millimeter because we could be compressing on the nerve and cause pain or paresthesia. Okay, we want to be very, very careful where we place implants. And if you're doing a full arch surgery, you should be comfortable exposing the mental foramen so you can directly visualize it and avoid it. On average, it's about 25.5 millimeters from the midline to there, roughly between the premolars, 98% of the time. And there are instances of double and triple foramen. I showed you this earlier, but about 3.5% of patients will have a double foramen. I bet that number seems higher than you'd think. Triple foramen, about 0.4 in this study. And I'll be honest with you, I don't see them that frequently. I think they're probably at a very high tolerance for what they're calling double and triple foramens in these studies. I would say it's more like maybe 1% has a double foramen that's any sort of size that's noticeable. Okay, but you do have to be mindful of the double foramen and treat both foramina as the real deal. You can't just like pick one and cut through it. But we do want to be able to expose the nerve trunk. This is what it looks like. You'll see the concavity in the mandible. You don't even have to go this far. Kind of once you see that clear concavity and you already know based on your CT roughly where this thing is, mark it and move on. Be aware of the anterior loop, like we talked about earlier. A little bit more than half of people have this thing. It just means that your implant needs to be 2 millimeters in front of the extent of that loop. Okay, and this is an interesting one. The retromolar canal is one of those things that once you start looking for them, you'll find them very often, is a small branch of the IA that comes off roughly in the retromolar area. And if you're having a second molar that's really difficult to get numb, they just can't get numb, it might be this little guy. And so you can go back and look for it. Here you can see it. If you look at this left image, probably nothing pops out to you, but then when I've pointed it out, you can see it now, this very distinct offshoot. So getting that numb, and you can get a decent bleed back there if you're doing third molars as well. Okay, we mentioned this earlier, but the incisive branch is a non-important branch that innervates the anterior teeth that are more than likely not there if you're coming anywhere near this thing. It does anastomose with the sublingual arteries at the genial tubercles. So one thing to be concerned about is if you're flapping a mandible that's quite resorbed and you're going to be anywhere near the genial tubercles, just be aware that there is an artery there. And cutting an artery outside of the bone is a lot more dangerous than cutting one inside the bone. You saw the videos earlier of a bleed from inside the bone that's easily stopped by placing the implant or gel foam or bone wax, whatever. Cutting an arterial that's in the soft tissue can retract under the floor of the mouth and cause a life-threatening issue. So here's a really good example of one, very large one, that just anatomically, patient had kind of superior genial tubercles, and that's where it exited. And so we were being very careful as we did our alveo to avoid that. We did some ligature ties just in case. So if it did get cut, it wouldn't bleed. And those are silk ties, and they were just left in. They resolve in about 3 years. And we all consider silk to be non-resorbable, but give it enough time and it will. So for deep suturing, silk is a nice one because you know the knot's going to hold. All right. Here's a video courtesy of my friend, Dr. Rounds. You can see a pretty good pumper from that arterial there. First thing you got to determine when you find a bleed is where's it coming from? Is it the bone or the tissue? If it's the bone, we're going to try to crush the bone around it or maybe stamp it somehow with bone wax. If it's tissue, the first thing I'll usually do is 1 to 50,000 epinephrine lidocaine and then try to get some sort of pressure on it or maybe a suture. Okay. Now here's what we haven't talked about yet is also the new thing in the AIS software is the AI bone segmentation built into the software itself. So previously I was going to cloud services and spending about $15 to $20 for a bone segmentation. And now in a matter of about a minute, which is 10 times faster than what I could do on the cloud, I can get an entire maxilla or mandible segmented. And once that's been segmented, then you can do all sorts of stuff with it. You can edit it, you can print it, you can export it. You can make guides that are directly based on the bone itself. And so I've done a couple guides since using the Optima's new software that pull the teeth, flap the tissue, and the guide rests right on top of the bone that was segmented out right there in the software. So it saves you a lot of time and money and gives you a lot more options when it comes to guided options and treatment planning. So a lot of times I'll take the bone models, and you'll see it here. There's the maxilla. So it converts the DICOM data, which is just a bunch of slices, into a 3D model that you can manipulate, move, edit, export, print, etc. So you can see just how distinctly it outlines all via artificial intelligence. It's pretty impressive stuff. Ways I like to use it is to pre-plant. When I put my implants in, I'll edit the bone segmentations for the alveo. And then I can actually print it. And in my office, which you can't see, there are several alveoplastid models, but I'll take into surgery with me, and then I can directly reference that model. For instance, if you're looking at this case, and we've segmented out the teeth and the bone, you can see how accurate this is to the actual real deal. Okay. Now, this on the left, I'll print this, so I'll have a 3D model in my hand, and I can measure, for instance, the socket of number 6. And then I go in the mouth and measure it in the mouth, and I can determine if I'm at my planned plane yet based on what I'm holding in my hand. You know, oh, I know I should have exactly 6 millimeters left of socket number 10. And I go in the mouth and check. And it's a lot easier than trying to click through the software, do a measurement, go to the mouth, and so on. So it's nice. Here's the plan as well. So you can see where the plan was versus the ideal. And it's nice because they come out, you know, they segment it out hollow for the sinus. So if you print it, you can actually have a really nice thing for sinuses because you've got this model you can use. So here's that same case. You can see just to plan. Pretty cool. Okay. So this is the model we'll use for sinus surgeries. And there's nothing like a pseudo-blind technique in the sinus where it's a lot of by feel, when you can hold the model and see the different anatomy of the sinus here. And then one last case I'll show you, a more advanced All-in-X technique on the maxilla. If we have a person who has a very large sinus, like we see here on the upper right, our spread of our implants can become detrimental to us. We don't have as much. We're only here at the first premolar versus the second premolar. Whereas we can plan a longer implant that's called transsinus and allows us to actually go through. And so with these models, we can get a very accurate representation of what that's going to be like and plan our surgery for something like this that not only goes through the sinus but re-engages the lateral nasal wall. And so having this kind of model printed in hand, even do the surgery on the desktop first with some other like dummy implants is really convenient. Okay, so that was that case there versus the plan. And it's amazing what you can do with the software nowadays that allows you to really pre-plan stuff and get ready to go. All right. Okay. Finished a minute late, so apologies about that. But got through all 160 slides. Thanks for putting up with me. I know I was talking really fast, but Q&A, if you have any questions, I've got the Q&A pulled up here. And we'll go ahead and all right. Thank you, John. Thank you, V, for the compliments. Yep. Of course. Thanks, Rose. Thanks, Mohammed. Thanks for hanging out with me on a Monday evening. It's only 5 o'clock here, so for some of you, I'm sure it's quite a bit later. All right, everybody. Have a great rest of your week and happy holidays, happy New Year, and all that stuff. We'll probably see you sometime next year. All right. Cheers.